Hello, everyone, and welcome to the PT on Ice Daily Show. My name is Christina Prevett. I am one of our lead faculty in our older adult division. And today I want to talk about a case study with a client of mine that, if you looked from the outside, would have seemed like a pretty easy peasy successful case. From the inside of my reflections, this was probably one of the most challenging cases and one that I've thought and reflected on a lot, um, that I've had in the last couple of years. So, I had a referral from a personal trainer that I work closely with that focuses in a 50 plus age demographic. She had 2 weeks ago injured her upper back, and he was looking for some guidance with what happened. She is a very active early 70s individual. She is a caregiver for her son that has special needs. She is a retired nurse, plays pickleball, and is an avid, obsessive pickleballer 2 to 3 times a week. She is a golfer, and she also is at a resistance training program multiple times a week with my colleague. So, very, very active. Needs to be very, very active in order to meet the demands of her life. Medical history is fairly insignificant, except for she's on some cardiovascular meds, blood pressure and cholesterol that she was on, or sorry, she had been on them, and then healthy lifestyle stuff had been able to get her to get off them. And she had a history of osteoporosis, including fragility fracture. So she had had a previous spinal fracture, and then she had had a fall several years ago in pickleball that caused her to break her wrist. T scores were in the minus 2.0 to minus 3.0, depending on the site. Um, Lots of conversations she had had about her osteoporosis with her doctor. She had trialed a couple of different meds. She really hated them. They made her very nauseous. Her side effect profile was really intense. And she made that decision, much to the chagrin of her physicians, that she did not want to be on the meds. She would rather focus on resistance training, impact training, and exercise modification if needed. In order to manage her osteoporosis. And I highlight this because it is a really important part of her story. So, a couple weeks ago, she has a deadlift that's in the 100s, 120s, 130s, has, with osteoporosis, has lifted and had never had an issue. They were switching up and doing an ab exercise, and they did a captain's chair exercise, which she was kind of hanging on her elbows and trying to lift her legs. And the point pressure of where her spine had hit her pad, all of a sudden caused this point tenderness in her mid upper back T6, T7 area. Didn't really go away, didn't really think much of it. Comes to see me a couple weeks later. So she is now about 10 days, 14 days post injury. She is still playing pickleball, but she notices that, she used to do 2 or 3 games. Now, after one game, she's starting to get this very sensitive point tenderness in the middle of her back. She is still trying to deadlift, but anything too heavy hanging in her arms is causing, again, that pulling sensation across that part in the middle of her back. And she is looking for some guidance. And then my personal training colleague was looking for some guidance for me around what he needs to do in order to manage this injury. So we kind of go through our exam, but you can probably figure out that I am very much leaning to this is a spinal fracture. Here's where on the outside, this case looked like a slam dunk, but on the inside, I was very uncertain. In our literature and in our guidelines, when there is a suspected spinal fracture, individuals, because I looked these up to make sure that I was kind of trying to do my due diligence after her first appointment. We are suspecting a spinal fracture. We go and get a X-ray to confirm. And then all of our management guidelines is protection for 6 weeks, and then a much stronger urgency to get these individuals on bone conserving medications. And then, we're worried about it becoming unstable and something being an issue. Where I struggled was number one, the x-ray wasn't going to do anything for her in this instance because I brought up the medications again and she was very adamantly against it. And so she was in this place where our next step should have been, confirm spinal fracture. Then they would have locked her down for 6 to 8 weeks of don't do anything, but she has to transfer her son. There is nobody else to do it for her. She is still playing pickleball and her pain becomes low level 3 to 4 after she is playing for a game. So she's already paying for 30 to 40 minutes and she has not had any adverse events to continuing in the gym, continuing pickleball, transferring or helping with her kiddo, etc. And so where I struggled and where I had to have this, evidence informed conversation was that we have what our evidence is saying. I have what my client is doing and is willing to do, and these things are on opposite ends of the spectrum. And so I am so conflicted about what to do in this case. And so I go with the education forward. So I say, I cannot rule out a spinal fracture here, right? I cannot rule out that you did not have a fragility fracture here because of your osteoporosis and your history. Our guidelines would suggest that the next thing that you would do would go to get a spinal fracture or an x-ray to confirm the fracture, and then they would have different discussions about medications with you. That is what they would say. What I am hearing from you, and I want you to confirm with me, is that even if this was a spinal fracture, you are not willing or going to go on these medications. And that is kind of where your stance is right now. And you have things at home that even with a spinal fracture, you would still be doing from an activity perspective. And she kind of confirmed that. And so in that, we kind of followed the guideline, and then she brought in her own informed consent process, when it came to her care and management. And so I said, for the next 6 weeks, it is really important that we do not push the amount of muscular activation and pulling that you are seeing in your back, your upper back. And so the first conversation was, I can't rule this out. And so because of that, I'm going to go in with the assumption that there is a fragility fracture present and go through my due diligence from that perspective. We are going to work on exercise elimination, substitution, modification right now to make sure that we are bringing your risk profile down as much as possible. And then you can make an informed consent process about what you are going to continue to do and what you are not going to continue to do. Because the reality is that her life was set up in such a way that complete deconditioning was not helpful, nor was it possible. And so we kind of had this conversation. So we took any heavy load hanging in her arms because that was pain provoking. We brought load down of anything that was going to activate the upper middle back. No axial compression in her exercise. I told her not to let this get pushed past a 2 or 3 out of 10 pain, and to just watch for any additional signs and symptoms, radiating pain, anything like that would cause us to elevate our level of concern around this injury. And so I followed her and she found that arc of, once she got to that 6 to 8 week mark, she was able to do a little bit more before she noticed that point tenderness. I saw her every week or two to just ensure that everything was okay. I was talking regularly with her personal trainer, that she was not heavy loading, that she was not doing too much. I was doing light soft tissue work distal to her fracture because she was having a lot of guarding responses around her back. Very, very, very light manual therapy was helping guide her around starting to work on some of, as we got out of that kind of acute zone. We were starting to strengthen up the muscles in her back and her capacity to carry more in her hands. And within 12 to 14 weeks, she was, not having pain in her mid back. She was able to get back to her deadlifts that were pretty heavy and was back to full level of activity. When it came to this case study, the most important thing was this evidence informed bridge, right? Where we have one area where the research is saying one thing, and then the lived experience of the human in front of us is saying that this actually isn't going to work very well for them, or they're just not going to go with the gold standard. And so on the outside, like, this was fairly uncomplicated. Her pain threshold was actually quite low. Her irritability was low. She was able to continue. Her fracture appeared quite stable. And I attribute that she had so much strength around that fragility fracture as a reason. Um, and I was able to guide her as much as possible. I doubted every single part of my process. I questioned every decision. I was uncertain every single part of the way. And I was honest with that with her. And I think she appreciated that because her experience, in her osteoporosis care and her injury recovery as a master's athlete, because she did tournaments, she was at a competitive level with pickleball, was her doc for osteoporosis basically made her feel really bad that she wasn't going to have the medications, despite the fact that, she's a caregiver for her child at home, and it would make her nauseous and make her flat out on the couch for days per injection. And then she had her wrist fracture from her fall when she was playing pickleball, and her orthopedic surgeon was like, "Oh, I wish all my seniors would stop playing pickleball. I hate to see you guys coming," was his response to her. And again, that made her feel really trashy. Like, you just are not listening to me. You are just telling me to do less. You are not listening to my lived experience, and you are not respecting the fact that, these are things that I really enjoy. These are things that are areas of my occupation that give me joy, comfort, purpose, friendship, social connection, etc. And that had been her interaction with healthcare for quite some time. And so when we are in this area where we are living in the gray, and unfortunately, or fortunately, maybe in geriatric practice, we're kind of always trying to do our best with many competing parts. This was one of those areas where I wasn't certain that I was doing the right thing. And, it could have gone a very different way. I felt in my decision making that I had done my due diligence to make sure that she knew where my brain was. I told her what the guideline was for fragility fracture and what the management plan was. She accepted that risk, knowing that she was not going to go on medications. That was not something that she was open to, and was willing to come alongside me. She was very open to me with her feedback around what she was feeling in her back with respect to activity, and was very good about not pushing it, especially in that 6 weeks protective mark. And then she felt good about the decision that she was making to continue doing some activity, significantly less. She was at probably 30 to 40% of what she was doing prior to her fracture, and then ramped up her intensity from there. And so this is one of those areas where I think it's really powerful in geriatric practice and anywhere where we have our research hat and I have my clinical hat, and sometimes they are fighting with each other. I talk about this a lot in our older adult live course because we cannot fit humans into little boxes sometimes. And when that happens, sometimes we deviate, or we have to try and make the best possible choice. And I love that evidence informed practice is that trifecta of what our current best evidence says, what our clinical experience is telling us, and our clinical decision making, and the desires of the patient that we are working with. And really, that patient should be in the center of our decision making process, and we become their GPS, not their driver. So this is a case that I still think about. Let me know, like, are you like, oh my gosh, Christina, I can't believe you did that? Or would you have done the same thing? I would really love to hear your experience. If you have any other questions, please let me know. If you are trying to figure out where the older adult crew is, please jump into our MMOA digest. That is our biweekly research email. My next course is up in Minneapolis, May 1st, 2nd. So hopefully I will see some of you there. Otherwise, have a really wonderful rest of your week, everyone, and we'll see you all next time.